I'm Dr. Jasmine Brown, naturopathic doctor and lab medical program manager at Postscript, and I'm so happy you guys have joined us today. The focus of this webinar series is vaginal health. In today's first session, we'll discuss the pathophysiology of genitourinary syndrome of menopause and introduce the Comprehensive Hormone Plus Profile, a non-invasive salivary test for assessing hormonal imbalances. Leading today's session is Dr. Lylan Ferret, a naturopathic doctor and director of clinical education at Doctors Data. Dr. Ferris oversees a team of physicians dedicated to educating practitioners worldwide on functional testing. In addition to her leadership role, Dr. Ferris maintains a clinical practice in Portland, Oregon. She is an internationally recognized speaker known for delivering engaging and insightful education at functional medicine conferences, webinars, and seminars across the globe. Before we get started, a few quick housekeeping notes. Please submit your questions in the chat, and we'll address as many as possible after the presentation. This webinar is being recorded, and the recording is sent to all attendees and registrants via email. You can also access it at fullscript.com/webinars in a couple of days. There will be a 5-minute break between each session. Thank you again for joining us today. Take it away, Dr. Ferris.
Thank you, Dr. Brown, and thank you to Fullscript for having me. So as usual, our disclaimer is that today's information is just for educational purposes, not for direct patient care. So the topic today is vaginal health. So we'll do an overview of vaginal health today and talk about the roles that some of the different hormones play. And then I'm going to talk to you about the Comprehensive Plus Profile and how that can help you determine what type of treatment might be appropriate for your patient. So what we have typically called vaginal dryness or vaginal atrophy is now more correctly referred to as the genitourinary syndrome of menopause, or GSM, which is probably how I'll refer to it moving forward. And essentially what this is referring to is the symptoms that affect not just the vagina, but the urethra, the whole sort of genitourinary area, because we know that during the menopause, really starting in perimenopause and then through the transition into menopause, levels of hormones drop. Estrogen is the primary influencer with vaginal health, but there are other hormones involved too. And as these hormones drop, the walls of the vagina can become thinner and drier and can be inflamed, and that can result in a lot of symptoms. Generally, we're thinking about burning, irritation, itching, maybe pain, especially with intercourse, even bleeding and discharge. And then some women have an increased incidence of urinary tract infections or incontinence or dysarthria, hematuria, or even polyuria. Additionally, for some of us, GSM can affect the ability to have an orgasm at all or make it difficult to achieve or have the intensity of orgasms that you once did. So taken all together, these can be very impactful. And we do, again, call them now the genitourinary syndrome of menopause. And it's pretty prevalent. While we still have our hormones, we women, only about 15 of us generally experience GSM. But then as we move into menopause, it's usually about half of us that do. And of that half of women who are experiencing GSM, we see that most of us have a decrease in estrogen. And that results in most of these women, up to 75% of them, experiencing what is typically communicated as dryness. And there's a lot of pain, and also these issues with urinary urgency and frequency. Even though women are experiencing these symptoms, a lot of them are suffering quietly because this is a vulnerable area, right? A lot of us don't feel comfortable discussing sexuality or things that kind of happen below the belt. And so they may not be telling their providers about the issue due to embarrassment, cultural beliefs, etc. And if the providers aren't actively asking patients about this, then they may not get care for it. And as a result, what we're seeing now is only about a quarter of people who are experiencing symptoms are getting appropriate care. So we as providers need to remember to ask about these different symptoms associated with vaginal and urethral health. Because I like this image because it shows us what can happen. So on the left, we see a vagina that's affected by having enough hormones circulating, primarily estrogen. But when estrogen starts to drop, the vagina can actually shrink, and this nice thick tissue with these nice rugal folds starts to thin out. And the vaginal canal can actually narrow and shorten. And so what that ends up affecting is that we have less vaginal fluid, aka dryness, which changes the acid balance in the vagina. It also changes the glycogen levels. We'll learn more about that. And all of this ends up making the vaginal tissue more delicate and more prone to irritation. So here's a little bit about what's happening pathophysiologically. Because estrogen plays a critical role in maintaining healthy blood flow and balanced microbiome in the vagina, when it starts to drop, we see problems. Estrogen also maintains the elasticity of the tissues, the thickness of the tissues, and the moisture. It supports collagen, healthy collagen growth. Additionally, and this is what the second lecture today will talk about, but it affects the microbiome because as estrogen levels drop, we see changes in glycogen levels, which affect the microbiome, and lactobacilli species are the prominent strains in the vagina. And so the pH changes, and then the makeup of the microbiome changes. So the tissue in the vagina is mucosal tissue, means it's not keratinized, right? It's very open to absorbing hormones and secreting fluids. And when it dries out, that's a problem. So we have this stratified squamous epithelium, which is set up to be very resilient in the face of friction, right? If we think about what the vagina is typically for. But again, when the hormones start to drop and there's no lubrication or protection against pathogens or irritation, we can have problems. We have to continue to get that mucosal secretion because it will help us fight off pathogens and keep our microbiome healthy. So it isn't just estrogen, although that's the primary hormone. Progesterone, testosterone, and cortisol can also play a role, and I do want to touch on those briefly. But I'm going to start again with just a little bit of a deeper look at estrogen, and I'm going to fold androgens in here because they do work together. And by androgen, I'm typically talking about testosterone. Anytime you see DHEA mentioned, it's typically in its role as a prohormone, which can become testosterone. So the roles of estrogen and testosterone in this area are that they keep, so I'll start with loss. If we're losing estradiol and testosterone, we can see the thinning of the vulvar tissues, thinning of the vaginal tissues, again, loss of that collagen and that elasticity, that narrowing of the area. Glycogen decreases. We see a decrease in the microbiome, specifically the lactobacilli, which results in less lactic acid. And we see a higher pH, which leads to an immune response. And we have less secretions, less discharge, so that equals dryness. And then, of course, with the urinary tract being so close to this area, the urethra can move closer to the introitus because everything's retracting when we lose those hormones. And then again, we're more prone to urinary tract infections. So the benefit of replacing these hormones is that the estrogen now will be present in amounts that are significant enough to maintain that blood flow, maintain that collagen, maintain the hyaluronic acid, maintain the pH, protect from pathogens, because there are receptors in all these tissues that respond to hormones. When it comes to androgens, the role is mostly to stimulate nerve fibers, maintain a healthy epithelium. And again, like I said, DHEA can typically convert to testosterone. Now, you'll often see estriol mentioned as being impactful with vaginal health, and it really is, especially in women who you may want to avoid estradiol for whatever reason. Breast cancer or a history of is often a reason to want to avoid estradiol. But estriol is a really wonderful option. There are three main estrogens, estradiol and estriol. And estriol is considered the weakest estrogen, but when it comes to vaginal health, it can actually work quite well because it does work like it can support the vasculature, the collagen growth, the glycogen secretion, and maintain a healthy microbiome. We also know that estriol can help manage those recurrent TIs, and it will not equate to growth of the endometrium, which is often an issue with estradiol, which is more of a proliferative hormone. And I also just wanted to mention here with estriol that it can also have some really important immunomodulatory benefits. There have been some interesting studies on estriol for autoimmune disease. And I'm just here referencing a study that is investigating roles for estriol to treat a wide range of menopausal symptoms, plus help protect against osteoporosis, cancer, hyperlipidemia, vascular disease, and multiple sclerosis. If you have any reservations about Estradiol can really be beneficial in a lot of ways. Cortisol is too, in the way that it impacts glycogen and the microbiome. If cortisol is elevated or being secreted irregularly, it can interrupt that. When we think about progesterone, there's really no linear association between progesterone and vaginal dryness, but it can help to maintain vaginal mucus. We know that it makes it thicker in cycling women. So there may be a role there, but certainly if you're giving estrogens therapeutically, you're going to want to give progesterone therapy as well, especially if your patient still has her uterus. Thinking about hormones and the microbiome of the vagina in particular, what we think we know, we probably don't understand all the mechanisms, but what we think we know is that estrogen seems to be the most important in promoting the growth of lactobacilli species. And again, that's by supporting the glycogen secretion. We know that postmenopausal women who are not on hormone therapy typically have lower glycogen levels and then lower levels and diversity of the lactobacillus species compared to those women who use hormone therapy. So in the conventional model, typically hormone imbalance is not tested for at all. Usually treatments are based on symptoms. But if you do want to test hormones, which I highly recommend, I want to talk to you about an option, a salivary hormone profile called the Comprehensive Plus Hormone Profile that Doctors Data offers. Because hormone imbalance is like a fingerprint. Every woman's hormone imbalance will be a little bit different, and identifying it can really help you be targeted in your treatment. And the reason why I like saliva therapy is because it gives a better indication of tissue levels of hormones, better than you get in serum or urine. So if your patient is seeking hormone replacement therapy, BHRT or otherwise, needing to know active hormone levels is important. And additionally, if you're someone who uses transdermal hormone therapies, saliva is the best place to track it because of steroid hormone physiology. So these are some of the hormone symptoms that might lead you to test hormones. In saliva, you can see vaginal dryness is listed here, but for both men and women, there are a wide range of symptoms that might lead you to salivary hormone testing. So the Comprehensive Plus Salivary Hormone Profile tests these hormones, 3 estrogens and estriol. And with that information, the estrogen quotient is calculated. Also progesterone, which allows us to calculate the progesterone to estradiol ratio, testosterone, DHEA, and 4 timed cortisols. And again, this is the best option if you're using transdermal hormones. And a lot of us do because they avoid first pass. So this is what a report would look like. Adrenal hormones on one page and sex hormones on the other. So the comprehensive profile is the option that's similar to this, but it doesn't test estrone and estriol. So why would you want to do the Comprehensive Plus that includes these extra estrogens? Because it gives us a little bit of deeper information about breast cancer risk in particular, but also issues like polycystic ovarian syndrome, autoimmune disease. But anytime you've got a population who is at greater risk of breast cancer, which is all menopausal women, or if someone has a personal or family history of breast cancer, getting these extra estrogens can be really beneficial because the estrogen quotient is one way to assess breast cancer risk. So this was developed by a doctor named Henry Lemon, who realized that women who were developing mammary cancers had lower levels of estriol, and rodent studies that he did where he gave estriol prior to radiation therapy showed that they were not developing as many mammary cancers. So this quotient essentially is estriol, the more protective, weaker estrogen, divided by the sum of estrone and estradiol, which are the more proliferative estrogens. So an EQ of greater than 1 is associated with lower risk, but an EQ of over 1.5 is considered optimal. The other ratio that's calculated with this profile is the progesterone to estradiol ratio. So you guys have probably heard the term estrogen dominance. Estrogen dominance it lives on despite the fact that it's not quite right. We're not really talking about an excess of estrogen like we see here in the first example. This is estrogen dominance, but the second example is too. What we're really talking about here is progesterone insufficiency. Estrogen dominance means there's not enough progesterone present to counterbalance the proliferative effects of the estradiol. And so this ratio allows you to determine if progesterone would be a benefit to your patient. Now, you're always going to want to collect all 4 samples, even if you're not running a full comprehensive plus profile, if you're maybe just testing the sex hormones. And why do we ask you to do that? It's because hormones are secreted in a pulsatile manner. So this chart shows you saliva samples that were taken every 10 minutes from 2 females. And you can see how much they change up and down because hormones are not secreted like you turn on a garden hose and they just flow. They're pulsed, right? This is just how physiology works. So when hormones are pulsing, if you take these spot levels, imagine if we caught this woman here versus here, we'd have a very different idea of how to treat her. So getting an average allows us to be a little bit more efficient with our therapies. So what the laboratory at Doctor's Data does is we take a small aliquot from each of the 4 tubes that have been collected at appropriate points to test diurnal cortisol, and we mix them all up into a pooled tube, and it's from the pooled tube that we test the sex hormones. And this yields more significant and clinically useful results. And this is what the profile might look like for a postmenopausal woman. This is an average peek at what you might see. So we can see all the estrogens are within the reference interval, although the estradiol and the estriol are towards the bottom end of the reference interval, and the estrogen quotient is low. So if hormone replacement therapy is something that you do in your practice, you might consider both estradiol and estriol in this case. If there's vaginal dryness too, that's the topic of today, but also just if you're trying to prevent lower breast cancer risk or treat any of the symptoms of menopause, really. The progesterone level is within range for a postmenopausal woman, but postmenopausal women don't make much. And so you can see here the ratio between estradiol and progesterone is quite low. So that means progesterone could potentially be an option. DHEA levels decline as we age. So this is pretty typical to see in postmenopausal women. Her testosterone level is not bad at 13, but certainly it's something that you could consider supplementing with based on symptoms, especially if you wanted to use it vaginal dryness was an issue. And you can see here that those 4 timed cortisol levels allow us to give you an idea of what cortisol does over the course of the day. This is our graph. Green would be optimal, and here we're skirting the bottom. So this is the type of information you can get from the Comprehensive Plus profile. So in summary, we know that hormones decline in menopause. They can start declining in perimenopause, which increases the likelihood of the genitourinary syndrome of menopause. So testing your patients can be a really helpful tool because it will elucidate their own particular, which allows you to be very targeted in your hormone therapies. All right. Thanks so much, everybody. I know we have maybe 8 minutes left for questions.
Yes, thank you so much, Dr. Ferris. That was wonderful. We do have a few questions. The first is, can you use saliva testing to monitor sublingual hormone supplementation?
You can, but of course it's trickier. And if you Google this question, you'll see a lot of different answers out there. A lot of docs say you can't use saliva testing to monitor sublingual because you're taking a sample from the same place you're applying the hormone, essentially. So it's very easy to contaminate with sublingual hormone use. The laboratory has some steps to take to lower the likelihood of contamination. So essentially, after you've utilized the last dose and it's absorbed, you want to really cleanse your mouth, rinse it out really well, brush your teeth, and then probably you'd want to use a different toothbrush in the period between the last hormone usage and the collection day so that you're not re-inoculating yourself with that toothbrush. So once you make sure that mucosa is cleansed, you're more likely to get a clean catch when you go to get those saliva samples. So it's possible. It is a little bit more challenging, but it certainly can be done.
Thank you for that. I wouldn't have thought about switching the toothbrush, so that's okay.
You know what? I have the benefit of looking at hundreds of these saliva samples every week, and so that's something we figured out over time.
That makes sense. All right. So the next question for you is, I know you have a different reference ranges for like premenopausal and menopausal women. How do you classify someone who's had a hysterectomy but still has her ovaries?
Yeah, that's tricky, right? Because if we use menstruation to decide when someone has reached menopause or not, the rule is if a woman still has her ovaries, but you can't use menses as a guide, we use the age of 50. So women who are 49 would be premenopausal, women who are 51 or 50 for that matter would be post. And you would have to use your own judgment to determine which range would be more appropriate. But the truth is, Once the uterus is removed, the massive blood supply that's there to keep that organ healthy diminishes. And so often women, even though they've kept their ovaries, will move towards menopause a lot faster than women who keep their uterus intact.
Gotcha. Okay, that's a good rule of thumb. Our next question: if the vaginal walls thin as we age, does that develop a prolapse?
It certainly can contribute to it. Prolapse, because we're losing collagen, and so we're losing integrity of some of those tissues. And so usually prolapse will also be initiated by pregnancy or other things that have stretched the tissues and the ligaments, leading to some innate weakness. But certainly we see that those prolapses will get more significant after menopause, and using hormones systemically, but also on those tissues, can be beneficial. Now, if it's to the extent that surgery would be of benefit, it's not going to help in those cases, but it can help for sure.
Next question. It looks like this is referring to an acronym on one of your slides. Is the PG
Or progesterone.
progesterone? Perfect. And then, is it true that the labia minora often goes away in menopause?
Yeah, it can. I've even heard stories, I haven't seen it myself, but I've heard stories of women whose vaginal tissues retract so much that there's not even really a vaginal opening anymore. That introitus just disappears. And this is just because these tissues don't have estrogen, plus the benefit of these other hormones, and they shrink and the collagen goes away. And so they retract and they get taut and they lose all that rogate. And so all of that is true. So using hormones on the area, even starting in that perimenopausal transition, can keep that from happening. And certainly if you have a woman who is interested in maintaining an active sex life, that is going to be really important to try to keep any of that tissue shrinking from happening, because it's so much easier to prevent than to reverse.
Right. Don't we see that all the time? If we can get in there before it happens, it's usually better. So our next question: why saliva over dried urine for testing sex hormones?
This is a really big question, so I'm going to give you my nickel answer, but it comes down to steroid hormone physiology. And so there's a lot of disagreement and controversy in this area, and there certainly doesn't need to be. But I've done a lot of reading and research on where to find hormones and sex hormone physiology. So we know that hormones are made from a fatty backbone, a cholesterol background. We know that oil and water don't mix. We know that serum is watery, and hormones that move around in serum have to be attached to a protein carrier like sex hormone binding globulin or albumin. In the urine, it's also a watery environment, so hormones have to be attached to a water-soluble side chain like a hydroxyl group, that kind of thing. And also urine is a waste product. So anything that we're urinating out is conjugated. So it's been changed in the tissues, the liver, or sometimes peripheral tissues, into these conjugated forms and excreted. So urine can give you a rough idea of what's going on at the tissues. Based on my research, I'm comfortable saying that salivary levels are more indicative of what's actually in the tissues than those other two. If you're more comfortable with those other methods and it's working for you, that's great. But like I said, especially if transdermal hormone supplementation is being utilized, salivary hormones will give you very accurate results again and again.
I've never heard it explained that way, but that makes a lot of sense to me. So thank you for going through that physiology and how it's changed and transformed in those different tissues.
Yeah, it's a really important piece. I always struggled with chemistry and thought, my gosh, I can't wait to get this behind me. I'll never have to think about it again. And unfortunately, that's not true, because chemistry is the language of the body, and we've got these different compartments, and things have to change molecularly if they're going to be able to be found or freely available in those various tissues or substrates.
Yeah, definitely. Okay. We got time for a few more. Do you need progesterone if you've had a total hysterectomy?
My answer is yes. So conventional wisdom would say probably not, but there are progesterone receptors in so many tissues besides the uterus. I say yes. I typically always give progesterone to women, whether or not I'm giving them estrogen, because it's a very important hormone on its own.
Okay. That makes sense. And then this will be our last question. Does Doctor's Data offer cotton rolls to collect saliva? It looks like it's much easier than spitting into the tube.
Yeah, no, we don't. And my understanding of the reason why is that the matrix in these collection devices makes it more difficult to test sex hormones. It interferes in some way. So if you're only doing it for cortisol testing, it's appropriate and allows people who maybe have trouble making saliva an easier collection. If the sex hormones are included, it just doesn't work as well. For people who have trouble making saliva, some tricks are smell something fragrant, like maybe slice a lemon, and that kind of sharp citrus smell can make the saliva flow. We also, the staff at Doctor's Data once read a review article on how frying bacon can make saliva flow. So sometimes just those aromatic foods that kind of trigger hunger can start the saliva flowing and make it easier to collect. And also make sure you're hydrated. You don't want to drink too much water before, like minutes before collecting, because then you could dilute the sample. But in general, if you're well hydrated in the days leading up to collection, you'll have an easier time.
Yes, that's a very good collection tip. I like the frying bacon piece. Oh, thank you so much, Dr. Ferris. And thank you all for attending and participating in today's session. If we didn't get to your question or you have a specific question about a report or test, please feel free to contact Dr. Ferris directly at lferris@doctorsdata.com. A quick reminder, the recording of this session will be sent to all attendees and registrants, and you can also access it in a few days at fullscript.com/webinars. We'll now take a 5-minute break before our next session. I do encourage you to join us for the second session entitled Elevating Women's Health Through Optimizing the Female Microbiome. This will be presented by Jennifer Olson. It's a fantastic follow-up to what we've already covered.
Thank you, everybody.